I think in continuation with the previous IC, it's my pleasure to welcome you all again on our IC, which is on common oculoplastic procedures. It's primarily a video-based presentation. And we have tried to cover common oculoplastic topics here: entropion, ectropion, blepharoplasty, levator resection, frontalis sling, canalicular lacerations, and external DCR. And we have got here very, very experienced oculoplastic surgeons. Maya Hada, Dr. Anita could not make it, unfortunately, because of some health issue. Then Dr. Kasturi, Dr. Ashok Grover, Dr. Santosh Honawar, and Dr. Fairoz PM.
Good afternoon to everyone. Thank you, sir.
Welcome, Fairoz.
So once again, I welcome everyone. And as it has been intimated just now, we are also having an important keynote address by Dr. Don Kikawa. So I think we shall have that in the beginning of session itself. And keynote address by Dr. Don Kikawa would be on changing landscape of aesthetic surgery. This will be for 10 minutes. Dr. Don Kikawa, we all know that he is the professor of clinical ophthalmology at University of California, San Diego, and he is also chief of ophthalmoplasty and reconstructive surgery there. So we look forward for this particular lecture by Dr. Don Kikawa. Please.
I'd like to thank the organizers of the All Indian Ophthalmological Society and Congress for inviting me to speak. I'll be speaking today on the changing landscape of facial aesthetic surgery. As we all know, aesthetic patients require extra time, extra patience, and extra understanding. This talk will cover how to apply your best gifted faculties as an aesthetic surgeon, and will cover anatomic tips, understanding of the aging process, learning from suboptimal outcomes, and aesthetic trends. The challenges are how to succeed in an aesthetic environment where we can offer no guarantee, but perfection is expected. And I think it's best to learn from what others have said about this. The Dalai Lama had a great quote, "If you can, help others. If you cannot do that, at least do not harm them." Anatomy is destiny. This is an example of some of the anatomic relationships of the SMAS and SUP. These are some dissections I performed as a fellow many, many years ago. On slide left, we see the SMAS, or superficial musculo-epineurotic system, in this cadaver. On a higher magnification view, we see that the SMAS is anchored in several points along the lateral orbital rim. This continues down along the inferior orbital rim and is characteristically known as the orbitomalar ligament. This is a transition zone between the lower eyelid and cheek, creates a demarcation line, and because of this connective tissue supportive system, there's less submuscular fat, which is leading to an area of fat atrophy. This is a clinical examination of a photo shown on slide left, showing these demarcation lines, and on higher anatomic dissection taken from a photo of Dr. Mark Lucarelli's classic article on midfacial aging, we see the lamellar nature of the orbitomalar ligament. Understanding of the aging process involves multiple areas of thought. We see deflation along the inferior orbital rim, and we notice on clinical photo, best seen in side view, that this area becomes unmasked along the inferior orbital rim. This is particularly noted in this anatomic cross-section where we see the SMAS overlying the bony structures. You can see along the SMAS, there's a large area of both premuscular and submuscular fat. However, along the condensation of these ligamentous fibers along the inferior orbital rim, there's a paucity of fat, hence leading to this area of demarcation. This is best clinically seen in the overlay photo of this patient on slide left, showing the three very classic periorbital demarcation lines. First, we have the lower eyelid crease, which forms at the junction of the lower eyelid retractors and the inferior tarsal border. Next, we have the orbitomalar ligament forming along the infraorbital rim. And finally, we have the zygomatic cutaneous ligaments with the condensation of fibers where the supportive midfacial structures are noted. An interesting study was performed by Alan Wolk, presented at the ASOPers meeting about a decade ago. It's well known that Val Lambros has studied facial landmarks and concluded that the primary facial aging change was deflation. We also know that studies by PESA have shown that there have been some loss of bony structure with bony retrusion as part of midfacial aging. Alan Wolk's study showed that gravity was still a cause of aging. What he did was he took 50 subjects and compared photos from 10 to 15 years prior, looked at and had masked observers look at both upright and supine photos, and found that the supine position recreated images of youth. This is a photo taken from Alan's study. On slide left A, the patient is upright. On slide B, you can see the patient is now in the supine position with restoration of volume with really no surgical procedure formed other than just laying the patient flat. The conclusion was that gravity does create a very significant note in terms of facial aging, and that it was not all deflation. And we think about what Gandhi said, honest disagreement is often a good sign of progress. Upper lip flat fat is another area where we notice very distinct changes. This is a patient in her 90s. You can see there's striking loss of the superior pre-epineurotic fat pad with relative preservation of the nasal fat pad. And this is a pattern that is commonly seen in aging, again, very deep central sulcus, followed by a fairly preserved nasal fat pad. We designed a simple study with grading of fat pads in this pre-epineurotic area. You can see fat pads are graded on a scale of 0 to 3, 0 being the most hollow, 3 being the most full. We also graded the nasal fat pad, 0 being the least amount of nasal fat pad, up to a grade of 3, which is very prominent. And then we plotted patients over a decade of life. So we took the average score as patients progressed from the 20s to 30s, all the way up to the 8th decade of life. And you'll notice that the pre-epineurotic grade of the fat in blue declined as patients got older. And the red shaded area had a relative increase as patients got older. Hence, the nasal fat pad did appear to be relatively age resistant, whereas the pre-epineurotic fat pad was noted to be more atrophic. How does this affect our clinical care? Well, in general, when we perform blepharoplasty, we prefer to preserve the pre-epineurotic fat as much as possible. We can conservatively remove the nasal fat, and we can also use the nasal fat as a graft if we would like to use this to fill in other areas. Suboptimal results are typically something that most physicians and patients may see if they are venturing into cosmetic surgery. And it's best that we use this opportunity to learn how we can avoid these results in the future. We have the obligation to provide the highest level of care for our patients as primary surgeon, and we have to be diplomats and care for the complications of others should they happen. This is an example of a patient who underwent previous lower lid blepharoplasty, and as you can see, perhaps with the overzealous removal of skin and possibly the inattention to lower eyelid laxity, this patient developed severe lower eyelid retraction and canthal dystopia. With reconstruction of the midface, hard palate grafting, and canthoplasty, we were able to successfully alleviate this problem and help the patient with their exposure. Injectables are here to stay. There may be newer materials, which could be longer lasting, and there could be the class of completely newer agents such as Kybella, which is FDA approved for the improvement in neck fat. But be wary of the newest and best to come out. Progress in medicine takes time. Patient safety must be paramount. And be wary of any marketing or new technologies which are often done for economic gain. What will have staying power is surgeons that will learn to perform the same procedures through smaller incisions, creating faster healing time and minimal downtime. Learn skills rather than purchasing the latest and greatest gadget to come out. This is an example of being wary to embrace the newest trend. This was back in 2006, where a machine called the Rytec Plasma Portrait was marketed to regenerate skin using pulses of nitrogen gas. At the time, the original asking price was $65,000, and as recently seen on eBay, it could be purchased for as little as $2,500. So always remember that it's a privilege to take care of any patient. Experienced patients know what is best for patients. And remember the Dalai Lama's sage wisdom: if you cannot help people, at least do them no harm. Thank you very much.
That was really very good. It was like icing on cake for our IC. Now we move ahead with our original IC. And it's my pleasure to invite here Dr. Maya Hada. Dr. Maya Hada is young, charming, and very dynamic oculoplastic surgeon. She is working as associate professor at SMS Medical College, Jaipur. She'll be today speaking on senile entropion surgical management. So we look forward to hear Dr. Maya. Dr. Maya, please.
Thank you, sir, for having me as a part of this wonderful IC. So I'll be speaking upon the surgical management of senile entropion. So we know that the senile entropion occurs predominantly in the lower eyelid due to the involutional changes in the eyelid. So let's see what is the anatomy of the lower eyelid. It is basically the lid position is kept in its place by virtue of some lower lid retractors, that is the capsulopalpebral fascia, and horizontally by virtue of the canthal tendons. So what happens with age is the laxity of all these tissues, predominantly the dehiscence of the retractors, as well as the hypertrophy and overriding of the preseptal orbicularis muscle. So there is an interplay of all these factors leading to involutional entropion. The forces which balances the eyelid, that is the forces which pulls the eyelids downward and outward, is then nullified by the forces which elevate the eyelid and pulls it inward. So we have to surgically correct both of these two components. First of all, if we see the dehiscence or disinsertion of the lower lid retractor, then we can notice this dehiscence by checking the inferior cul-de-sac that is deepened, as well as we can see the increased vertical excursion of the lower eyelid, and this is addressed by the plication of the lower lid retractor. So taking you
I request others kindly keep yourself on mute.
So this is a video showing the Jones plication of the lower eyelid. This was a case of a senile entropion where the incision is being given beneath the beneath the lash line, 4 mm below the lash line. There is then separated by the sharp and blunt dissection. We have to identify the lower lid retractor, that is the white hideous retractors. We can find them just anterior to the palpebral conjunctiva, and they are analogous to the LPS epineurotic, the upper eyelid. We can also feel the tug when we ask the patient to look down, and here we can see that the retractors are identified, and we have to insert them, reattach them with the lower border of the tarsal plate. So we take a full thickness microsphere through the retractor and then pass it through the tarsal plate. From the tarsals, we take a partial thickness slide, and while tying the knot, we watch for the inversion of the lid margin. We have to just adequately correct the lid margin entropion. Don't want it to be overcorrected or any entropion on table. Especially when tying the medial knot, we don't want the conversion to occur. Some surgeons prefer to do it in a single layer by incorporating inorbicularis also in the suture when they are tying the knot to the retractor and tractor. But I prefer doing it in 2 layers. After that, the excess redundant skin is trimmed, and then the skin and the orbicularis is closed with the interrupted 6 marks suture. To check the adequacy of the procedure, we can ask the patient to forcefully close the eyelid and check whether there is inrolling of the eyelid margin on forceful closure or not. If that's not happening, then that means the procedure is sufficient. Other thing to address is the horizontal eyelid laxity that can be checked by a snapback test and the distraction or pinch test. And this we can address by doing an horizontal shortening procedure like a lateral tarsal strip. Lateral tarsal strip is a very popular surgery which all general ophthalmologists also should know and perform. This is being done under local anesthesia. A lid traction suture is passed. Then we perform a lateral canthotomy followed by lateral cantholysis. Then we mark the amount of eyelid that we want to shorten up. Usually 4 to 5 mm of shortening is needed. To freshen up the tarsal strip, we first have to denude all the skin overlying the tarsal, the anterior lamella from the lid margin, as well as we also excise the conjunctiva from the posterior part of the tarsal strip. So this will create a tarsal strip and we will measure that. Here it is around 4 millimeters in length. This tarsal strip we have to reattach over the lateral periosteum. So at the point where we want to create the new lateral canthus, it's preferred that we attach it slightly above that, prevent any post-op sagging that may occur. Then we pass a double arm suture by any non-absorbable monofilament suture. Here I am using a echelon, and then we tie it over there and create a new lateral canthus. While suturing the upper and the lower lid margin to create a lateral canthus, the bite should also be taken from the newly formed lateral tarsal strip, give a depth to the lateral canthus. And after that, we suture the skin by 6 muscle. If there is overriding of preseptal orbicularis over the pretarsal orbicularis, then that can be addressed by doing an everting suture or a transverse lid split along with everting suture. It creates a fibrous band to prevent the overriding further. Other alternative is the modified Wheeler's procedure. So to conclude, I'll say the understanding of the anatomy, pathophysiology, and the etiological factor is crucial in the diagnosis and management of involutional entropion, and the combination of techniques with adherence to basic principle gives the best results. Thank you.
Thank you, Dr. Maya, for highlighting senile entropion so very well. You have covered almost every procedure which is done for senile entropion. We shall have discussions later on. So now I'll invite Dr. Kasturi. Unfortunately, as I told initially also, Dr. Anita could not make it because of some issues, health issues. So Dr. Kasturi will be speaking on blepharoplasty. I think she has got maximum experience of blepharoplasty out of all Indian surgeons. And I have seen her operating cases of blepharoplasty. She does it so effortlessly, it's a treat to watch. So let's hear Dr. Kasturi on blepharoplasty simplified. Dr. Kasturi, please. Please unmute yourself.
Can you, am I seen now? Am I audible?
Yes, now you are.
So I'll be speaking on blepharoplasty simplified. So at the outset, I would like to thank Dr. Mukesh for having me in his course. It's really wonderful to be in his course, and like he plans it so meticulously. And also there's so much learning tips from everyone that I listen to you in every session. I've been learning so much from each one of you. So I'll be speaking on blepharoplasty, which is basically a surgical procedure where some amount of the skin, muscle, and the fat are either been excised. These are either being redraped or it is being molded. And this is classically come from the Greek word blepharon, which means the eyelids, and the plasticos, which means to mold. And today it is the most time-tested technique having both functional and a cosmetic indication. Functional, especially in situation of dermatochalasis and epiblepharon, where you have the lash ptosis, and we do the surgery to redirect the eyelashes so that it no longer touches the cornea. However, the most common cosmetic indication is the conversion of a single lid to a double lid crease. And this is a very simple procedure, which you can see here. The most important is how to do the marking. The marking is classically done by the pinch test, and you do the pinch and then you measure. Approximately, it should be 10 millimeter from the lash to the lower part of the margin, and another 10 millimeter from the eyebrow to the upper part of the margin. Then you excise a customized amount of the skin, excise the muscle and the fat. And once the skin, muscle, fat have been excised, depending upon what type of eyelids that you're dealing in, especially in the thicker eyelids, which we see in the East Asian, you need to excise some amount of fat. However, in the Caucasian or in the South Asian, you may not need to excise the fat. This has been followed by the lid crease incision, which we usually give in such situation, followed by the skin closure. And thus you can see that these are some of the patients who comes to us having a single lid crease, and they want a double lid crease, which should be present in the different days and in the different views. And the most important is the lid crease formation suture, so that it retains even for approximately 2 to 3 decades. So these are few of the patients, especially if the patient comes with ptosis, then blepharoplasty combo we can do, where along with the blepharoplasty, we can do a MMCR where you correct the ptosis, and approximately 8 millimeter of the molars conjunctiva corrects 1 millimeter of the ptosis. And the Putterman clamp really helps you to measure how much amount of the tissue you need to excise. I usually use a PDS suture and give a double row of the sutures, and also extrude the knot externally. And these are the results that you can see before and after the operation. However, another indication, and very recently I have come across, like, but now when I look more deeply into the lacrimal gland prolapse has become quite common, than what I feel, especially in the East Asian eyelids. And when you ask the patient to look down, you can see the the gland prolapsing also. Many a times with the blepharoplasty also, we do a repositioning of the lacrimal gland. As you can see here, the pale part is the lacrimal gland and the yellow is the fat. And I usually use nowadays, initially I used to use the proline, but nowadays I do not use much proline for any of the peristal suturing, because sometimes it gives way long, very late post-operatively. So I feel the polydec is a better suture for such situation, and you give a mattress suture and you reposition the lacrimal gland deep into the orbit. And this is being followed by excision of the fat and also the skin suture that you can see has been done in this girl. And this is how she looks. This is before the operation with the bilateral lacrimal gland prolapse, and this is after the blepharoplasty along with the repositioning of the lacrimal gland. So sometimes we get situation like this, which are real difficult situation, which is known as extended blepharoplasty. The only difference, you have to see the point C, where the point C we give in the lowest part of the lateral hoodie. So normally what happens in the cosmetic, we keep an incision up to here, but in such situation, you have to go incision beyond the lateral canthus, and then you excise the titrated amount of the skin or the muscle, as you can see here. But sometimes when you see real thick lips, then instead of making a crescentic incision, you can modify the incision something like this, which is known as a W incision. And then you go for the plication, because, and since we are already in the anterior approach, this will also take care of the ptosis. As you can see, the 4-lid blepharoplasty has been done before and after the procedure. But one of the major concerns that I have seen in all age and all ethnicity are the baggy eyes, for which we need the lower lid blepharoplasty, for which you need to differentiate whether this is a fluid or fat. For the fluid, if you ask the patient to look up, and on looking down, if it is still present, as you can see here, then this is basically a fluid. But in case of fat, if you ask the patient to look up and on looking down it is absent, this is basically a fat. So this is basically the negative vector, which we have already seen in the previous presentation. When we are young, the malar plane lies much anterior to the corneal plane, and this is known as a positive vector. And as we grow old, because of the changes, deflation, which Dr. Kikawa has already mentioned, the malar plane lies much behind the corneal plane, and this leads to development of the negative vector. So because of these changes, we gets a baggy eye, which is characterized by the stetoblephron, the festoons and the mounts, and this gives a classical, the double convex deformity. But along with it, we see the other aging changes like that of horizontal lid laxity. Maya has shown so well. There may be dermatochalasis, tear trap, and different type of furrows. But how do you manage? How do you know that which treatment to do in which situation? If you have a young girl like this with some of the baggy eyes, but not very prominent baggy eyes, and if you see the layer of the fat is much behind the anterior lacrimal crest plane, these are the situation when you can manage non-surgically, that is with a dermal filler. But if you have an elderly lady who comes to you with a much amount of fat prolapse and this fat lying anterior to the anterior lacrimal crest plane, so these are the situation where the blepharoplasty is the treatment of choice. And so in situation like this, with very amount of the fat prolapse, you can very well manage with a filler, and thus you convert the negative vector to a positive vector by doing a non-surgical procedures. So it is not that in all situation we do a filler, like when you have a prominent tear trough, or when you have a situation with little amount of fat and little amount of trough. These are the situation where you need to give an injection filler, and you get a very good result even without doing any surgery for such patient, as you can see here before and after, where the injections are given along the infra or by the rim. But if you have a lady like this with so much of lid lengthening, with so much of fat prolapse, fat lying much interior to the lacrimal crest plane, then this is a situation you need to do a blepharoplasty. So when we talk about blepharoplasty, basically the three types, which depends upon you take a decision on the length of the lid, which has been very nicely described by Fessa et al., where if the length is less than 13 millimeter, we just go for the fat removal. If it is between 16 to 19, fat removal with some amount of filling agent, and if it is more than 19, then we go for a tissue preserving technology, which is known as a transfer of the fat, and you get beautiful result. So in a young patient like this with only fat coming and the lid length is being much less, you can directly manage with excision of the fat, and you convert this negative vector to a positive vector without even giving a post blepharoplastic filler or a fat later. So a simple fat excision occurs in young patient where you have only a lid lengthening, a very less amount of lid lengthening. But if you have a lid lengthening like this with so much of fat prolapse, which is much interiorly coming up, much interior to the anterior lacrimal crest plane, then this is where you have to do a tissue preserving blepharoplasty, wherein what you do along with the blepharoplasty, you transfer that out to the soup. I think
Dr. Kasturi, I think you have gone on mute.
okay. No.
Yeah, now we can hear you.
So with this, I would like to conclude that yes, depending upon the amount of the tissue, like amount of the deflation, we decide whether we need to do a transconjunctival or a transcutaneous blepharoplasty. So thank you very much for the patient hearing.
Thank you, Dr. Kasturi. You have highlighted the basics of blepharoplasty and also all the finer points of blepharoplasty, I think, which is only possible after thorough understanding of the subject. So we shall have a good discussion, I think, on blepharoplasty also at the end of our session. Our next speaker is Dr. A.K. Grover. He will be speaking on ligator resection pearls. We all know Dr. A.K. Grover and know how wonderful surgeon he is. We have seen him operating also. So let's look forward to hear Dr. A.K. Grover on ligator resection. Grover, sir.
Sir, you're muted.
It's 1 o'clock.
Okay.
Okay. Good afternoon again, and thank you, Mukesh, for making me a part of this prestigious course. I'll be speaking on levator resection for ptosis, and I'll be speaking both on congenital and acquired with the little differences in the techniques. In congenital ptosis, we would normally do it if the levator action exceeds 4 mm, which would usually be associated with either moderate or severe ptosis. Practically, I would do it when levator action exceeds 6 mm. Anything less than that would usually imply it would be a Whitnall's sling. The surgical technique essentially implies choosing the sweet spot, which usually to me comes somewhere in the middle of the lid, middle of the eyelid and center of the eyelid, and the lid crease, which is marked to match the fold on the opposite side, which is usually a combination of margin crease distance as well as the tarsal plate show. So somewhere in between that, when you use a paper clip or a little forceps with 2 prongs, you can judge the position very well. When you go through, you need to use some xylocaine with adrenaline in most cases to get a good hemostasis. And if your anesthetist permits, if it is a 1 in 80,000 solution, it's a good option. So once you made the skin incision, you can dissect between the tarsal plate and the orbicularis. And then the next dissection plane is between the orbicularis and the orbital septum. Once the orbital septum is identified and opened, you can see the pre-epineurotic pad of fat, which is retracted to expose the levator aponeurosis. And the cutting of the horns is usually not done these days, and we want to preserve the maximum possible function of the Whitnall's sling as well. A dissection on the conjunctival aspect, leaving molars behind. You dissect between the molars and the levator aponeurosis. Once this has been done, you start with your insertion of the suture at the center of the eyelid corresponding to the sweet spot. Normally, I would use a 6-0 or a 5-0 vicryl suture. The bite is in the central, 3 bites are all in the central third and just a couple of millimeters below the tarsal border. It's passed as a partial thickness bite through the tarsus, and then it is taken through the position which you have judged on the basis of your preoperative findings. It is usually close to Whitnall's, and the distance from Whitnall's would determine the amount of correction you would get. And the table assessment is important. For somebody with a levator action of 8, I would leave it where I want to leave it. For those with a higher levator action, I would leave it maybe a millimeter lower. And for those with a lesser action, I would go higher. And then you make your temporary sutures, assess the correction, finalize the sutures. And then in those cases where there is a need and where your initial assessment suggested that the lid fold would be better with a little skin excision, you would do a spindle of skin excision and close the wound. So let's look at the video, which would show the steps again. This is the dissection between the orbicularis and the tarsal plate. You define the fibers of levator aponeurosis on the tarsal plate, which are then opened out. As we know, the fibers come down on the surface of the tarsus. And then this is the dissection between the levator and the orbital septum. The orbital septum is opened. It can be multi-layered and until you see a clear exposure of the pre-epineurotic pad of fat. And then you retract the fat to see the levator. And the next dissection plane is between the conjunctiva molars and the levator aponeurosis. I do not inject any adrenaline on the conjunctival aspect now, and I find that makes my dissection simpler. It's the right plane that is important. Once you have gone through, you can see the fibers of molars there. And then you define the Whitnall's. You start with your tarsal bite in the center. And then take a bite close to Whitnall's depending on the levator action with a double arm suture. First temporary tie would give you the amount of correction. Once you are satisfied, this may be assessed under GA by trying to put the globe in the primary position. and then you put the medial and the lateral sutures. Once the three sutures are, the sutures need not be too far peripheral because they would give notches. Once the sutures are in position, you can give a temporary tie to all the three, assess the contour, and only when you're totally satisfied with the correction and the contour that you finalize these sutures. Then you can remove the extra part of the levator aponeurosis. If no skin excision is required, you go ahead with formation of the lid crease. 3 to 5 sutures are usually used, 3 sutures. Now I don't take the bite with the absorbable suture on the upper aspect. I only take a bite through the lower aspect of orbicularis and to the deeper part of the distal part of the aponeurosis, and then skin closure is carried out. So the results can be quite gratifying in mild ptosis with little lid lag or lag of thalamus. In moderate ptosis, the results are good in about 80 to 90% of the cases, but lid lag and lag of thalamus would be a little more. But severe cases where you do a Whitnall sling, where you go through the Whitnall in your bites, you would get a good correction, at least early. Some cases tend to droop by the end of 6 months. This is again another Whitnall sling, but the lid lag and lag of thalamus would be a significant problem. The acquired ptosis cases, we will talk about all these entities. Okay, I'll just take half a minute then. So the aponeurotic ptosis essentially requires a reattachment of dehisced aponeurosis, and you may need to modify it according to and do a little hangback in those with very good levator action, and the results can be gratifying. It is a good technique for traumatic ptosis as well, but with the fair levator action and lot more scarring. Residual ptosis, again, it is a very good technique for those with significant levator action. Mechanical ptosis, you need to combine with the debulking, excision, and then it can be a very predictable, fairly predictable procedure. You need to guard against the intrinsic complications, complications of undercorrection, overcorrection, lid notching, entropion, bad lid fold, and superior fornix prolapse. And thank you.
Thank you, sir, for being so crisp and lucid as always. Now it's my pleasure to invite Dr. Santosh Honawar. Dr. Santosh Honawar will be speaking on silicone sling, and we all look forward to hear Dr. Santosh on silicone sling.
Thank you, Mukesh, for the opportunity. I would like to speak on tarsofrontal sling using silicone. It's a wonderful course that we are having, and I would like to just be a small part of it. The indications for tarsofrontal sling are any child under 5 years with unilateral or bilateral sling, where you do what is called a temporary sling. That means that there would be a need for using a reversible material, and silicone sling comes handy in such a situation. You can use suture for sure, but the advantage of silicone is that it has its inherent elasticity and surface tension, because of which the child need not use the brow so much. So this works well, and it is completely reversible. But when we do it in an older child, say 5 or 6 years, with unilateral or bilateral ptosis, with severe ptosis with poor LPS action, then it becomes a semi-permanent or a permanent sling. Semi-permanent, I would say, because sometimes it does need adjustment, and adjustment is always possible. Now, the ideal qualities of a sling material are that it should be biocompatible, non-biodegradable, biointegrable, which fasciolata is, so it is not reversible or adjustable, should be flexible, easily available, and should provide for easy handling. Silicone meets all the criteria except that it is not biointegrable, so it is beautifully adjustable and reversible. This is a video clip that shows the procedure of surgery. It's an 800 micron pre-swatch sling, which is available pre-swatch in an atraumatic needle. This is a 4-year-old child. We were doing a pentagon, that is a marking 8 millimeter apart on either side of the limbus or within it. And the superior medial and superior lateral incisions are in line with the medial and lateral canthi respectively. And the suprabrow incision is about 8 to 10 millimeter from the superior orbital margin. Then I would prefer to take a traction suture through the eyelid, porosil, and a lid guard or spatula is used. A small scratch incision in the epitarsal plane, not to injure the tarsus, and the stab incisions in the medial and lateral suprabrow areas. Central forehead incision, a pocket is made in the subcutaneous plane to bury the sling finally. The needle, which is flexible, is bent to the suitable contour, and it is passed from the central forehead incision to the lateral suprabrow incision, making sure that there is a play in it. That means you haven't caught the anterior or posterior lip of the wound. Horizontal passage over the tarsus in the epitarsal plane, not through the tarsus. Make sure that you haven't perforated the tarsus full thickness. It can happen with a sharp needle and a thin tarsus. And go back to the medial suprabrow incision. Again, come through the middle of the incision with a horizontal play, and finally complete the pentagon by passing the sling back over to the central forehead incision with a 3 to 4 millimeter gap between the first and the second arm. Then you pass the sling through the sleeve, which is a 1300 micron sleeve loaded on an artery forceps. Unload the sleeve with your finger. Don't use any sharp instrument to do that, and tighten the sling. Ideal position is 1 millimeter from the limbus or at the limbus. There will be some bunching up of tissues initially, which is nothing to worry about. That is part of the process, and then it settles down because we have lifted the lid artificially. So bunching is common, but not so much. And then you lock the sleeve using a 6/0 crowley. Cut it about a centimeter long so that future adjustment is possible, and bury the end. And then you take a suture tarsography suture. See, this is an example of a unilateral silicone tarsofrontal sling. As I said earlier, patients don't have to use the brow so much because it has its inherent surface tension. This is again a patient with unilateral tarsofrontal sling. You can see that with the use of brow, the lid position can be much higher than where you have left it with. So you can actually give control over the sling to the patient so that minimal lag of thalmus is there. This is bilateral tarsofrontal sling. And this is again a bilateral tarsofrontal sling. You can maintain lid crease symmetry as well as the eyelid height symmetry. And the advantage of silicone is that the closure is much better than any other material. Since it is so elastic, patients can close their eyes with minimal 1 to 2 millimeter lag of thalmus. Nocturnal lag of thalmus may be slightly higher. And in situations where there is a chronic progressive external ophthalmoplegia or myasthenia gravis, which has not responded to medications, or patient cannot use medications, we do what is called a safety enhanced sling, where we do that with a suture tarsography, which can be release graded. This is a neurogenic ptosis with a silicone tarsofrontal sling by the safety enhanced method. This is a patient with bilateral chronic progressive external ophthalmoplegia, where you correct only to expose the pupil, not overcorrection at all. And to show that even in patients with bilateral CPO, closure of the eye is acceptable. They don't have too much of lag of thalmus or corneal exposure. In patients with neurofibromatosis, you can debulk and then do a sling. Silicone sling can take the weight of the bulky eyelid despite having residual neurofibromatosis. In a traumatic ptosis where levator action is poor, again, you can do a sling, again to show that lag of thalmus is not so severe. Patients with blepharoplasty, of course, can also be treated with bilateral silicone tarsofrontal sling. So in conclusion, I would say that in a patient with severe ptosis with poor levator action, you have very limited choices, one of which is a Whitnell sling, which is a good technique, or supramaximal resection, as they say. This is useful in patients who don't inherently use their brow. But typically, silicone sling does not need the brow used so much on part of the patient. Of course, they can use it, but even if they don't use it, it leaves the lid at a reasonable height. Tarsofrontal sling is definitely a good option for patients with severe ptosis with poor levator action. And silicone is an alternative material to facial ETA, which is still the gold standard. The beauty of silicone is that it is totally reversible and adjustable. It does not get biodegraded, so you can open it up even after 7, 10, 15 years, just a forehead incision, and tighten the sling. As long as there is no epitarsal migration that has happened, which is a cause for undercorrection, you can always tighten the sling. And reversibility or adjustability will also mean that the control is with the surgeon, even post-operatively. If the patient has adverse, say, lack of thalamus or corneal exposure, you can always lower the sling to an acceptable level. And safety enhanced technique definitely helps patients who have high risk of corneal exposure. Thank you so much.
Thank you. Thank you, Dr. Santosh. So it was really a wonderful presentation. Now I'll move ahead with my presentation, and I'll be presenting today canalicular laceration repair. So my presentation is visible?
Yes, sir.
Okay. So canalicular laceration repair can be done as early repair or as a late repair, even after say 6 months to a year. Early repair can be done as primary repair or secondary repair. Secondary repair is typically done after 3 to 5 days of injury. Sometimes patient comes late, sometimes there is a lot of swelling. So we conduct repair after 3 to 5 days of trauma. So these are pictures of primary repair and secondary repair. There are certain steps of canalicular repair. Step 1 is finding the cut end of canaliculus, medial as well as lateral. Step 2 is applying pre-placed sutures in pericanalicular area. Step 3 is canalization of canalicular system, either by mini monoca stent or by Medicath or by other stents. Step 4 is tightening of pericanalicular sutures. And step 5 is suturing of associated laceration. So I believe we should follow this in this particular manner only, stepwise manner. So it's always better to apply pre-placed suture first, then to canalize the system and then tighten the pericanalicular sutures. So that will ensure the placement of stent inside the canalicular system. Then finding proximal cut end is quite easy, and finding distal cut end is made easier either by seeing directly under microscope, or sometimes we can take help of trypan blue injection or by injection of dye. If trauma is very bad and tissues are quite badly lacerated, then pigtail probe can be of great help. So now I'll go straight away to the video. So here you are looking at a canalicular laceration case. So finding proximal cut end is quite easy. You just pass a probe, it will come out there. Now to find the distal cut end, either you can look into the microscope. If it is not visible, then in this particular case, we will be injecting trypan blue injection from the opposite puncta. You'll have to give some pressure at NLD level so that this dye comes out at the cut end. So this is the cut end which can be made appreciable very easily by injecting this dye. Now you can pass your stent from the puncta. This is the mini monoca stent, and you can cut it short. I do not leave it quite long. I generally try to leave it at around 10-12 millimeter only. See the cut end of canaliculi. This is quite beautifully visible as it is made up of silicone or something like that. So you can just check the patency of canalicular by passing your stent. Then pass your pre-placed sutures. Your stent will come out, don't worry about it. First, pass these sutures by ato-vicryl. After passing your sutures, then insert your stent into the distal end of canaliculi. Your assistant would be holding the lid now, and then tighten your pre-placed sutures. After tightening them, then you do the associated lid repair. So this is very important to pass pre-placed suture, then reinsert your stent, and then complete the suturing. This is a case of delayed canalicular repair, very old case, maybe I think 3 years after trauma or so. There were bands here. Both the canaliculi were obstructed. So, and there was fistula also here. Lacrimal fistula was also there. So first, this tissue, fibrous tissue, was resected and probe. It has come out into the area. Now to find out the other cut end, we are using pigtail probe. So your non-absorbable ethibond suture has been passed. Now pigtail probe is passed from the other end. And again, there were obstructions there also. So again, this soft tissue was resected and this has come out into the opening. And then the part of the portion of non-absorbable suture was pulled. And then the conjunctiva was sutured. This suture was kept like this. One can thread a hollow silicone tube also over the suture. And this was left there. So we have now around 25% success rate in these delayed cases. But it is also worth trying, I believe. 25% success rate is also not bad. So to conclude, success rate with canalicular repair ranges from 20 to 100%. All fresh cases, success rate is more than 90%. In delayed cases, success rate is less. Stepwise approach of canalicular laceration repair gives gratifying results in primary repairs. So it should be attempted in all cases of lid repair with conjunctiva, with canalicular lacerations, even by a general ophthalmologist. Thank you for your patience hearing. Now it's my pleasure to invite Dr. Feroz. Dr. Feroz would be presenting on DCR.
Thank you, Dr. Mukesh, for this wonderful opportunity.
Unmute yourself.
Okay, one second. Can you hear me?
Yes, we can.
Okay. Thank you, Dr. Mukesh, for this wonderful opportunity in this excellent video-assisted educative course. So I go on to the last topic for today, external DCR and how to get it right. And I'm sure most of us here as oculoplastic surgeon would agree that external DCR is still the gold standard in nasolacrimal duct obstruction. And although, you know, I would agree that conventionally I do a lot more of external DCR. And you know, when you do a Google search also, when you do a gold standard in NLDO, it's definitely the external DCR which, you know, comes up. And what is the main reason why even me, I prefer a lot of external DCR in my practice is that the surgical success rate, it is as high as 99% with the modern technique of, when compared to the modern technique of endoscopic nasal surgery. And what we do here in a DCR surgery is where we are converting a 3-compartmental model to a 2-compartmental model where there is a direct communication between the tear lake and a nasal space where, you know, we incorporate the lacrimal sac. Way back in 1905, Toti described the first procedure, and thereafter there has been various modification which has been widely accepted. So what we really need to know in a DCR technique is first and foremost is the case selection, indications for doing an DCR surgery. So there are situations where a patient can present as a chronic dacryocystitis or a tearing, as in this patient, where, you know, after imaging with a suspicion of not being an acute dacryocystitis or a chronic dacryocystitis, this came out to be a cysticercosis, which was lying over the sac and compressing the sac and causing watering. Now, when I talk to the postgraduate students, whenever they go ahead and do the DCR surgery, they are scared of the surgery for the reason that it's usually a bloody surgery, and most of them consider it as a DC war surgery. But with a good anesthesia and hemostasis, DCR is not a difficult surgery to do. A local anesthesia, sometimes maybe a sedation might be required. General anesthesia is very, very rarely used in surgery. And hemostasis is something that we have to always be thinking about. Going on to the next slide, before we know and embark on the DCR surgery, it is very important to understand the facial vascular anatomy, lacrimal apparatus. All these hemostasis, the surgical approach, and reaching at the right basically depends upon knowing and the knowledge of the anatomy of the face, and we have to always avoid. And this is basically the anatomy of the
nice only. Yeah.
I think other people should mute themselves. There is some disturbance which is coming.
Shall I continue?
Audio visual people from backend can help. There is some noise which is coming. Please unmute.
Darjan ji, ek baar dekhna, somebody is on unmute.
Yeah, so basically the anatomy that we need to know is about the the fossa of the lacrimal sac and the lacrimals, you know, the adjacent structures. We all know it's very simple, not a rocket science. We have the medial canthal tendon. Then we have, you know, the canaliculi, which is lying just deep there. So even the size of the ostium, basically the applied anatomy and the landmark would be the common canaliculi, where superiorly we go 2 millimeters above. Inferiorly, it is at the junction of the nasolacrimal duct and the sac, and anteriorly we go a few millimeters in front of the anterior lacrimal crest. So identifying the anterior lacrimal crest and the posterior lacrimal crest is very, very important, which lies anterior and posterior to the fossa of the lacrimal sac. And of course, the medial orbital anatomy should also be known by a resident or anyone who does a DCR surgery. So the surgical technique of DCR surgery, keep it bloodless. It's not going to be difficult. So basically we identify the anterior lacrimal crest over here after elevating the periosteum. And usually the incision that we use is a curvilinear incision. It's a tear trough incision all along the anterior lacrimal crest, which is hidden in the the lower lid line, crease line. And then after elevating the sac, this is the mucosa, the nasal mucosa that you can see here in this picture, with a large hole anteriorly where the bone is closely adherent to the mucosa. We don't go beyond that. And as I mentioned earlier, inferiorly, it's the junction of the nasolacrimal duct and the sac, and a good flap. So I'm going to show this video over here. This is the best video that I could take, and this is very good for teaching, which I had with me during my fellowship, and I'm going to play you that today here. So this is a very precise video, very precisely taken, and this is a curvilinear incision which is taken in the anterior tear trough area, where you separate the skin and the orbicularis over here with a good hemostasis. After that, the periosteum is identified. The periosteum is elevated. This is the fossa of the lacrimal sac exposure. And after that, you enter the lamina papyracea at the junction of the ethmoid bone and the lacrimal bone. Dissect it well, make good ostium, as I told you, superiorly 2 millimeters above the common canaliculi, inferiorly up to the nasolacrimal duct. And after exposure of the nasal mucosa, the bony ostium is also slightly extended inferiorly. Now, this is the exposure of the sac mucosa. And then after application of the probe, you actually cut the sac mucosa. And finally, this is how the posterior flap is excised. And then the anterior flap of the nasal mucosa is sutured to the anterior flap of the lacrimal sac is sutured to the nasal mucosa over here. And then finally, yeah, it is tied together, and then it is the skin closure. So after that, we also do an anterior nasal packing in order to prevent. So these are the patients. This was a patient seen during the COVID time. So if you're worried about the scar, well, it's not too bad after doing external DCR. The scar is hardly anything if you take the right anatomical plane. And this is a middle-aged 32-year-old man who underwent external DCR, a 68-year-old who underwent external DCR. And the scar is barely anything. Thank you very much.
Thank you, Dr. Feroz, for being so meticulous. Once again, I'll thank everyone for being on time. Now we have got some time left for panel discussion also. We'll start with first talk, which was given by Dr. Maya on entropion. So I have one question with you, Dr. Maya. While doing LTS for entropion, do you do everting sutures always or sometime, or you do not do everting suture, you do not pass everting sutures?
So most of the time, the LTS itself corrects the laxity, and I prefer doing it in isolation without passing everting suture. And if at all there is a retractor dehiscence and I have to correct the vertical component as well, I prefer doing Jones plication for that procedure. So everting suture, I don't prefer doing that. I prefer, yeah.
Okay. Any other comment on this particular question by any of the panelists? Anybody would do everting suture along with LTS in entropion while doing entropion surgery? Dr. Feroz or?
I don't do it, Dr. Mukesh.
All right. In some of the cases, at least in my hand, whenever we are doing entropion surgery, we do have residual entropion while doing LTS. In ectropion, it's not that way. In ectropion, you don't require to pass in inverting suture while doing LTS, but in entropion, sometime I need to combine LTS with the everting suture. So that's my experience, whatever I have it with this.
So I have a question here just for the benefit of the audience and the viewers. What is the experience of using a botulinum toxin? Dr. Kasturi is also here in spastic entropion.
I think that is one of the indication for the spastic entropion. We go for botulinum toxin approximately 5 and 2.5. That is 2.5 medially and 5 units laterally, so 7.5. And it should not be near the margin, a little approximately 1 millimeter away from the lid margin. It really works good. And that is, we have been doing for many, many patients, especially spastic, and also some elderly people who refuses any sort of surgery, like having other comorbidities. Those are the patient also works very, very good with botulinum toxin. As I think what Dr. Mukesh was asking regarding the lead everting sutures, yes, sometimes with LTS, you need to place lead everting suture, especially when there is an ectropion. Especially when there is a very severe entropion. But supposing there's a case of ectropion, then along with LTS, you also need to make a conjunctival incision and also resuture the lower lid retractors to the tarsus. that gives a better correction. So sometimes you see the whole lid is everted. Like these type of ectropions are really difficult to manage when you have an ectropion from the medial to the lateral end. So this you need to do a LTS, you need to re-suture the capsulopalpebral ligament to the tarsus, and also you need to do a medial canthoplasty.
Yes.
Somehow, I don't tend to see many pure spastic entropions. I would only see them generally as a part of the involutional entropion only. And I would generally then need to operate. I haven't really had any indications where I felt that's just pure spasm which could be relieved by Botox. And I don't really see those kind of cases in my practice.
Those comorbid patients, very old patients, sometimes when they refuse surgery, then I just
involutional ones with the element of override. Yeah, they would do well. They would do well for the time being. The tarsal, the ectropion that you were speaking about, tarsal ectropion, that's very interesting. And those cases invariably require this triple procedure that you've spoken about. I invariably combine an LTS in them with a spindle excision, which implies that I would be taking those sutures through the capsulopalpebral head when I'm closing that spindle, and then I combine it with inverting sutures. So those work beautifully if you do a combination of the three. It doesn't work with one or two of any of those two combinations.
Exactly, sir. Even I feel those cases really requires a combination of the three procedures.
Those are mostly the cases with long-standing facial palsy, the paralytic ectropions. They have this lot of sagging and all these three procedures together.
Yeah, but even involutional ones do come.
Sometimes we get it.
Dr. Mukesh, can I ask one more question to the panel?
Sure.
Yeah. So this is for the respected panelist over here. If you have a medial ectropion, do you prefer doing the medial canthal surgeries, or it's like the posterior lamella that you would prefer?
Basically, there are 3 steps to it, saying how much amount is the ectropion. If the ectropion is very minimal, then you only need to cauterize the conjunctival side. That also helps you some amount of interning of those medial ectropion, which
Posterior
is
lamellar, basically, ma'am. Yeah.
you just cauterize the posterior lamella. Or otherwise, what the Dr. Grover sir has already mentioned, you cut the diamond, and then you put an inverting suture where you take the bite to the capsulopalpebral ligament. And the third option is a lazy T, which we do. You do a diamond on also a vertical spindle you need to cut. But sometimes what I do, but these type of real bad ectropion having a medial, central, and the lateral part of the whole lid being everted, then those are the cases you need to reinsert the lower lid retractors to the tarsus.
I distinguish between those where there is predominant medial palpebral ligament laxity and a medial eyelid laxity. Where there is predominant medial palpebral ligament laxity, I need to tighten that. Sometimes even going to the extent of going to the posterior crest to reattach. But that would be for the severer cases. And for the others where there is the punctum cannot be pulled too far, but there is a medial laxity, I would do a lazy T procedure in that. The full pentagon with the spindle, which spindle is a little deep, with a little cauterization to cause scarring, and a little deep suture again to take in retractors, as Dr. Kasturi mentioned. So those work well.
Thank you, sir. Thank you, ma'am.
So I think now we move ahead with the discussion on other talks. Dr. Kasturi, I've got one question on your talk. In one of your cases, you have combined MMCR along with blepharoplasty for ptosis associated. Why don't you do levator plication or resection always while doing blepharoplasty? What is the need of doing MMCR?
That lady had a positive phenylephrine test. So there are 3 options to it. One is the plication, which invariably I do for all Asian eyelids. Advantage of plication is that it will correct some amount of ptosis and also give a very permanent lid crease. That is for all Asian eyelids. And second is, if there is a phenylephrine test positive, then I prefer to do a MMCR.
Along with plication, or
if I do MMCR, this is only Bleph and MMCR. But if there is a lateral hooding or if there is an Asian lid, then all plication. And I feel plication, even for the CPEO, now we are also doing a very big research my fellow has taken up. I've seen that the plication also really helps in CPO, and we are trying to titrate how much amount of plication that needs to be done. That is a recent research that we are just conducting on it.
I do have long-term cases in CPO where we did a levator procedure, they have come back. And later we've had to do a sling. Yes, of course, it tides over a significant period of time with significantly less lag of thalmos than we would have created with a sling. So
Yes.
it's a procedure, helpful procedure.
And also I'm trying this not only in CPO for the Turner palsy and double elevator palsy. Like we are trying to see by now, I think we have done around nearing 10 to 15 cases. We'll combine more cases, then we'll know what is the actual results.
So you are doing levator plication or orbicularis plication in these cases?
Levator plication, and depending
But then the bells would be an area of concern in these cases.
Yes, but advantage, what I think Santosh had also mentioned it very clearly, these people do not have leg of thalmus. That is a very good advantage. So no muscle excision, no skin excision, only the plication. And at least they can just open up and they can see. And as because they do not have leg of thalmus, till now, amongst all the cases, we have not come anyone with exposure. Then this is just a research we have started very recently, sir. Like within this, I think from Jan or December we have started.
All
We'll
right.
wait for that.
Yes, sir. We need to follow it up more, but none of them is having any of the exposure, and ultimately they're happy. They feel we are also assessing the quality of life.
Okay. So you must be doing it under titration, like close monitoring and titration.
We are measuring how much plication, amount of plication works for ptosis, how much works in the myogenic ones, and how much it works for neurogenic ones. Like if it's a Turner palsy, actually, like so when I do for a normal ptosis, in my hand, 8 millimeter plication I need for 1 millimeter of ptosis. But we are just titrating how much it works for the neurogenic and for the myogenic.
Okay. I think is there any other question for Kasturi? Otherwise, we'll move ahead for the third talk. I think now I have a question to Dr. Grover. Sir, whenever you are doing levator resection close to the vitrinals, in these cases also you do not do horn cutting?
No.
As
Particularly in those cases, I would avoid any horn cutting. I've almost given up horn cutting for all cases because you can easily do that resection without disturbing the lateral support. And I don't think that is contributing to any significant lag of thalmos. And when you're doing vitrinals, it is particularly important that you do not do anything to weaken the strength of vitrinal and structures around. And the only difference that I have from routine levator surgery is that I'm using a Prolene sutures because I was wondering whether my late decay of correction that happens in these cases is because I'm using an absorbable suture. I don't think it has made that difference from the limited experience that I have. I don't have a controlled series to say that. But yes, I do still observe with vitrinal sling late over 3, 4, 6 months, the lids do come down to some extent. So,
lid lag is not a concern without cutting horn. I believe what I feel is that lid lag is little more if we do not do any horn cutting, especially wherever we are doing maximum or supramaximal resection of levator going close to the vitrinal.
yeah, I've nearly stopped doing maximal supramaximal resections. That actually implied that I would only do it if there is no defined vitrinals. And then I would go to that what strictly is defined as supramaximal is that you do 25 to 6 millimeters and pass your suture that far up. Those cases, of course, the horn has to be cut. There's no question about that. But vitrinals is just 15, 16, 18 millimeters away. You don't need to cut for vitrinals. For supramaximal, certainly, where there's no well-defined vitrinals, I would go ahead and, and I'm not getting a good correction in the region where I think Whitnall may be, then, and some of these are cases with fatty degeneration, with muscles that look too dystrophic, and they would not work well even with supramaximals. But then, yes, those without a well-defined Whitnall, and I am doing elevator surgery, I would do a supramaximal. And then certainly Whitnall, I will have to cut the horns.
That, sir, leads to another question. So, like in some of the cases, you go even beyond the Whitnall ligament also. My understanding was that's the maximum limit of aponeurosis which is available, Whitnall's ligament. Beyond that,
then in supramaximal, you're not just at the aponeurosis. Then you're going to the muscular part. There's no question about that. But you were doing that supramaximal resections for those cases where the Whitnall is poorly defined. You can't really get any lift by passing your sutures in the Whitnall's region. Though it is doubtful whether the supramaximal is also giving you in all cases, but in some cases, yes. And these are the cases which would go in for phonics prolapses and so on. And that is why I virtually not remember having done many supramaximals during the last 5-odd years, 5-7 years.
Dr. Honawar, any comment on these aspects? They here? No.
Yeah, I'm here. So I also don't cut the horns these days. I mean, in several years, actually, that is beneficial to maintain the medial and lateral contour, and it doesn't cause excessive lack of thermus. Supramaximal, actually, I don't do. If at all required, it is Whitnall sling that I prefer than supramaximal.
Yes, Santosh, the question is, are there occasional cases where there's no Whitnalls, with good Whitnall that you can see to get the support?
Yeah, so in that situation, going supramaximal will only cause issues of downgaze lid lag, which is more severe than sling and lack of thermus.
What is the option then? So, then you would convert to sling?
Then it is the best option is to convert to sling.
Sir, I have a question, sir. What is the maximum endpoint of LPS excision in case of Marcus gun?
I would cut the horns and go almost up to Whitnalls. I cut that entire thing out. Do a good separation from the conjunctiva millers. Do a good separation on both the sides with the good thorough cutting of the horns. I'm not worried about the integrity of Whitnalls or whatever, and remove that entire piece. Of course, most important is not to dissect on the surface of the tarsus, because I prefer to do a closed technique rather than fixation technique of sling. So my fascia lata would not be fixated, or my even my silicone would not be fixated to tarsus, because that doesn't give me a very good contour. It causes flattening if I fixate it. And there were earlier cases where I got an entropion as well. So I very much prefer the closed method, and I don't dissect between the tarsus and the orbicularis. But superiorly, yes, I would go all the way to Whitnalls and excise.
So do you go beyond Whitnall and pass a hook and also excise?
No, I don't.
And I cut the Whitnalls and go beyond.
I don't get any visual function of the levator.
Beyond the Whitnall?
Santosh?
Yes. I cut the Whitnalls and go beyond. Few millimeters beyond Whitnall and cauterize the posterior edge.
Cauterizing the posterior edge
the levator that gets retracted into the orbit because it bleeds, because you're in the muscular portion.
Okay, so hemostasis.
Yeah.
Like how we do for squint.
Right.
You believe that cutting Whitnalls will impart to better abolition of Marcus gun phenomena?
I haven't done otherwise, so I don't have experience. Sir has a lot of experience. So I mean, the way we were taught during senior residency, I continue to do Marcus gun. I haven't changed at all, actually. This was the classic teaching. I haven't done with the Whitnall sparing Marcus gun.
Mm-hmm. And in the temporal aspect, in the temporal aspect, you leave that part of aponeurosis which is under the lacrimal gland.
Right. You on the temporal side, you always cut medial to the lacrimal gland, so you preserve it and you make sure that you don't damage the lacrimal gland at all. Yet you can go cut the Whitnalls and go posterior to it. That is not difficult.
Mm-hmm. All right. Whatever experience I have, I think Marcus gun get abolished even if we do it as Dr. Grover has said ahead of Whitnall's. But yes, if we remove Whitnall's altogether, then there is no possibility of any residual Marcus gun phenomenon. All right. So now we move ahead to the other talk, questions on other talk on silicone sling. Dr. Santosh, do you feel that in any subset of patient, facial lata may fare well on over silicone?
Yeah, if a patient has amblyopic eye and has no stimulus to use the slinged eye, then maybe facial lata would be better, because facial lata is almost a non-dynamic sling. The patient does not have to elevate the eyebrow so much to lift the lid. It's a fixed sling. And in a permanent situation, if it's a bilateral situation, if it's a permanent situation where you know that you're not going to adjust sling ever, you're doing it at a particular age group, then facial lata may be preferred.
Unilateral or bilateral?
Either which way, sir.
Unilateral, I don't get any result. And with the maximum tightening that I do with fascia lata, unilateral, I get undercorrected. So I don't do unilateral fascia lata.
Case does, right?
I generally do not do unilateral facial lata. Very rarely I do. All unilateral cases, they allow me to do bilateral sling now.
Oh, really?
So that's the way I am doing it. And
He's become converted.
yeah, actually,
He got converted, sir.
or you feel good, doctor. So
If somebody says unilateral surgery, I would do a stylastic, because stylastic can be over tightened and I don't get the habitual palsy. I mean, on the table, I would get a good correction with fascia lata unilateral also, but post-operatively, it would invariably be a habitual palsy. So I would do a stylastic rather than fascia lata if I were to do a unilateral surgery.
For blepharophymosis syndrome, Dr. Santosh, are you happy with the result of Celastic?
Yeah, right. I'm happy with the results of Celastic, because when we operate at 6-7 years of age, they need an adjustment, but the closure of the eye is much better, and lack of thalmus is not an issue. So absolutely no problem.
Dr. Grover?
No experience with I will need to try. Like I was doing much fewer of stylastic until I heard Santosh, and I converted in a fair number of cases to stylastic now, unilaterals. And I'll try this also. I haven't no experience with stylastic in blepharophymosis syndrome.
Dr. Kasturi, you also do a fair amount of blepharophymosis cases.
I use fascia lata, only fascia lata for my fine, because the leaves are so phimotic, so thick.
Correct.
So
that's what my take also. It appears that these phimotic lid silicone would be insufficient to give a long-term lift, but your experience is otherwise. I think, as Dr. Grover said, maybe we are more obsessed with fascia lata, so we need to try it more often.
do you perform the lateral canthoplasty in all cases of blepharophymosis?
I measure, and then yes, of course, medial canthoplasty plus lateral canthoplasty in the first stage, and in the second stage I do sling. I don't do all of that together.
I used to do it in all cases, but I'm no longer obsessed with it. It takes away the beauty of the lateral canthus. Somehow, if I can get a large enough enlargement on the medial side, and also that appearance of the distance between the limbus and the lateral canthus, as well as a little rounding up. I can't get as good a margin after whatever lateral canthoplasty I do, and the beauty of the lateral canthus. So I think I have reduced significantly my lateral canthoplasties.
So I have restricted it to little lesser amount of lateral canthoplasty. I was also doing it quite deliberately, quite large lateral canthoplasties earlier on. I do it, but the area of lateral canthoplasty is now I do not do that much. Your concern is absolutely valid for me also, because it gives some rounding of that. So for Dr. Feroz, any questions? So I think with this,
Dr.
Our time
Mukesh,
is
there is one question for you from the box. Can you just answer that before
That's
you
so
move on?
important.
Yeah, can you please, Dr. Mukesh, can you please tell us your experience in patients where canalicular stent was not placed? What prognosis do they have and how are they managed in future?
well, this is a very good question. I have seen in few of the cases without canalicular stent, a good lid repair also leads to a patent lacrimal system. This is one. If somebody has done very good approximation of lid, nature also takes care. So that's one part of it. Second part, I think, which you are saying is that if somebody has done repair without placing a stent and later on patient comes to you, how do you manage? That's the way the question was? Or?
So Dr. Harika has asked this question. What prognosis do they have and how are they managed in future? Like probably the prognosis without a stent.
Okay,
That's what
okay.
she meant.
So point is that ideally in all cases, we should try to place a stent because it is an extreme less number of cases where you will have a patent lacrimal system if a stent is not passed. So I don't think we should leave patient for luck. And it's not at all a difficult proposition. Even if you do not have mini monoca stent, a 22 or 20 gauge MICATH or IV cannula is easily available that can be passed and suturing should be done around that. So leaving lid without passing a stent should not be the idea. So I think with this, our time is over. So I thank all my co-participants, all co-instructor for having this wonderful session. And we look forward for many more such interaction in the future. I also thank all the participants, all the attendees for being with us. Thank you once again. Thanks a lot.
Thank you.
Thank you, Mukesh. Wonderful session.
Thank you so much, Dr. Mukesh Sharma. You have been a wonderful leader and an excellent participation from all the speakers. I think this hall has been very happening, very pleasant and very happy.